I'd like to highlight for you our work on association of metabolic tumor volume and clinical outcomes in second-line relapsed refractory large B-cell lymphoma in the randomized ZUMA-7 clinical trial comparing axicabtagene ciloleucel CAR T-cell therapy to the existing standard of care of second-line chemotherapy with consolidative autologous stem cell transplant. So Axi-cel is a CD19-directed CAR T-cell therapy, and based upon ZUMA-7, a phase 3 global randomized trial, it is now approved as a second-line therapy for patients with large B-cell lymphoma who relapsed within 12 months of initial therapy. We know from the ZUMA-1 trial, which is that led to the approval as a third or later line in large B-cell lymphoma. In ZUMA-1, we found that tumor size was associated with outcome. In fact, patients with larger tumors, as measured by the sum of the product of the diameters, or SPD, on up to 6 reference lesions, those patients had worse outcomes in ZUMA-1. And so when we looked on ZUMA-7, the randomized trial, we were surprised to find that that wasn't the case. Patients with larger tumors who were treated earlier with CAR T, at least as measured by SPD, did not have worse outcomes, although patients who got the standard of care treatment with large tumors did have worse outcomes. And so that was a little bit surprising. We also had studied metabolic tumor volume, or MTV, which can be calculated from a PET scan. And this MTV has been shown to correlate with outcomes of CAR T-cell therapy in third or later line setting. And so we thought to look at MTV in the setting of the ZUMA-7 clinical trial. ZUMA-7 is a randomized 1-to-1 clinical trial, as I mentioned, with the primary endpoint of event-free survival. And the MTV was measured from the baseline PET scan prior to CAR T-cell therapy or standard of care therapy. And we looked at associations of MTV with clinical characteristics. One of the interesting things we found is that, yes, patients with a high LDH had a higher metabolic tumor volume, and patients who were younger had higher metabolic tumor volume, larger tumors than older patients over 65. We also found a correlation between the sum of the product of diameters, I mentioned SPD, and metabolic tumor volume, but it was not a strong correlation. It was a moderate correlation. So MTV is measuring more than that SPD. Similarly, LDH was a moderate correlation. So MTV really is capturing more granularly this tumor size in these patients. What we found, though, is basically that with axicabtagene ciloleucel, whether patients had large metabolic tumor volume or small metabolic tumor volume, they did better than standard of care patients. However, patients with small metabolic tumor volume did better with Axi-cel than those with large metabolic tumor volume. So it does stratify patients by event-free survival and progression-free survival. But interestingly, patients with large metabolic tumor volume who got the standard of care therapy did dismally. They did horribly across the board with really low event-free survival and progression-free survival. We also found an association between response. Patients who were responders had a lower metabolic tumor volume than those who were non-responders. And in addition, metabolic tumor volume was lower in patients who were complete responders compared with others. And then finally, we found an association between toxicity. Patients with grade 3 or higher neurologic events or grade 3 or higher cytokine release syndrome were more likely to have high metabolic tumor volume. There was no association with toxicities in the standard of care arm. So really, we concluded that to our knowledge, this is the first examination of metabolic tumor volume, or MTV, in a large randomized prospective trial of CAR T-cell therapy in relapsed refractory large B-cell lymphoma. And similar to prior analysis with SPD and LDH, Axi-cel was superior to standard of care for both high and low MTVs. But while tumor burden by SPD didn't predict for Axi-cel outcomes in ZUMA-7, low MTV was associated with improved outcomes with Axi-cel versus high MTV, as well as high MTV associated with toxicities. Again, patients did better in the Axi-cel treatment arm, whether they had high or low MTV compared to standard of care patients. And so taken together, we think that metabolic tumor volume is a better prognostic marker than some of the product of the diameters.